please. I'm going to test your vision.
Begin the eye examination by assessing the patient's visual acuity. Have the patient stand 20 feet from a Snellen eye chart. Patients who use contact lenses or glasses should wear them. However, patients should remove reading glasses because reading glasses blur distance vision. Note the visual acuity printed at the side of the line of the eye chart. Visual acuity is expressed as two numbers, for example 20/20. The first number indicates the distance of the patient from the chart, and the second number indicates the distance at which a normal eye can read that particular line of letters without the aid of corrective lenses.
And read the smallest line from right to left.
Repeat the test on the other eye.
D, Z, P.
Now prepare to test the patient's visual fields.
Now we'll test your visual fields.
For screening purposes, visual fields are tested by confrontation. Face the patient directly and imagine a glass bowl encircling her head.
Look into my eyes with both your eyes.
Ask the patient to look with both eyes into your eyes.
Tell me when you see my fingers.
Then place your hands about 2 feet apart lateral to the patient's ears.
Okay.
Slowly move your wiggling fingers of both hands along the imaginary bowl until the patient identifies them. Normally, a person sees both sets of fingers at the same time.
Okay. Tell me now when you see my fingers.
Repeat this action in the upper and lower temporal quadrants.
Now.
If you think you have found a visual defect, such as loss of vision in the right temporal field,
Good. Tell me when you see.
Slowly move your wiggling fingers from the defective area of the field toward the better vision.
Now.
Repeat this at several levels until you can define the border of the defect.
Now.
Then test the other eye for an accompanying defect.
Now. Now the other side. Look directly into my eyes.
Next, visually inspect the patient's eyes. Observe for alignment and symmetry. Also examine the eyebrows and closely inspect the eyelids. Normally, the upper eyelid covers a portion of the iris, but does not overlap the pupil. Inspect the area over the lacrimal gland and lacrimal sac for swelling. To inspect the sclera, the bulbar conjunctiva, and the palpebral conjunctiva of the lower lid, ask the patient to look up as you depress the lower lids with your thumbs. Normally, the bulbar conjunctiva is transparent, with vessels running through it, and the underlying sclera is white.
Good.
To see the palpebral conjunctiva of the upper eyelid, the eyelid must be everted. The palpebral conjunctiva is pink and uncongested. Carefully inspect each iris and pupil. Normally, iris markings are clearly defined, and the pupils are round and equal in size. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a penlight from the side toward the eye. You should see no opacities. Next, test the pupillary reactions to light. First, darken the room. Then ask the patient to look into the distance.
Look off in the distance.
Shine a bright light obliquely into each pupil in turn. The oblique lighting and the distant gaze both help to prevent a near reaction. Look for the direct reaction, consisting of pupillary constriction in the eye being illuminated directly. Then look for the consensual reaction, which is pupillary constriction in the opposite eye. Typically, in a darkened examination room, you will need to quickly illuminate the patient's opposite eye in order to provide sufficient light for direct observation of the patient's consensual reaction. Next, assess ocular alignment arising from the extraocular muscles. From about 2 feet directly in front of the patient, shine a light onto the patient's eyes and ask the patient to look at it.
Look at this light, please.
Inspect the reflections in the corneas. They should be visible slightly nasal to the center of the pupils. Next, assess the extraocular movements, looking for the normal conjugate movements of the eyes in each direction, or any deviation from normal. Nystagmus, lid lag, and convergence.
Now we'll test your extraocular
You will check the
muscle.
extraocular movements in the 6 cardinal directions of gaze.
Follow my finger.
These directions correspond to the coordinated action of 6 muscles involved in eye movement innervated by cranial nerves 3, 4, and 6. Stand 2 to 3 feet in front of the patient. Ask her to follow your finger, or a pencil, as you make a wide H in the air.
Now I'll test nystagmus.
Look for the jerky movements of nystagmus on lateral gaze and on upward gaze. A few beats of nystagmus on extreme lateral gaze are normal. In a patient with lid lag, seen in hyperthyroidism, watch for a rim of sclera between the upper lid and iris as the eyes move up and down. These movements should be symmetrical and conjugate. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of the nose.
Now follow my finger.
Eyes can usually follow your finger to within 5 to 8 centimeters of contact. Next, after darkening the room, conduct your ophthalmoscopic examination. Switch on the ophthalmoscope light and adjust it to the large, round beam of white light. Also, make sure the light is set to the appropriate brightness. Set the ophthalmoscope to the 0 diopter. Ask the patient to look over your shoulder at a specific spot on the wall.
Now look straight ahead at the dot on the back wall.
Remember to use your right eye and right hand as you examine the patient's right eye. From 15 inches away and 15 degrees lateral to the patient's line of vision, shine the light beam on the pupil. Placing the thumb of your other hand over the patient's eyebrow may steady your approach and allow closer examination. Locate the red reflex, which should appear as an orange glow in the pupil. Note any opacities that interrupt the red reflex. While holding the red reflex in view, approach the patient's eye along a 15-degree line lateral to her line of vision until the ophthalmoscope is close to the eye. Try to find the optic disc by following the retinal vessels centrally toward the place where they converge. Now, using your index finger, bring the optic disc into sharp focus by adjusting the diopter of the ophthalmoscope. Note the color of the optic disc, the clarity of its margin, and the size of the physiologic cup. Normally the disc is yellowish-orange to creamy pink and round or oval with well-demarcated margins. It may be surrounded by white or pigmented rings or crescents. The optic cup-to-disc ratio is usually less than 1 to 2. Adjusting the angle of your head and instrument and moving them as a unit, inspect the retinal vessels and adjacent retina by following the vessels from the disc to the periphery in 4 directions. Note the relative size and color of the narrower, lighter arteries and the larger, darker veins. Look for changes, such as nicking of the veins at arteriovenous crossings. There should be none. Examine the surrounding retina for hemorrhages or exudates, noting their size, shape, color, and distribution. Again, there should be none. Finally, examine the fovea and surrounding macula by directing your light beam laterally or asking the patient to look directly into the light. The tiny, bright reflection at the center of the fovea may help orient you. To focus on more anterior structures, such as opacities in the vitreous body or the lens, change the diopter on the ophthalmoscope to more positive numbers, such as +10 or +12. Repeat the ophthalmoscopic examination on the patient's left eye, using your left hand and left eye.